Um, okay, hi folks. So today we're going to be talking about sepsis, which is probably one of the most important subjects in clinical medicine. You guys can hear me okay?
Yes, Dr. Mark.
Okay, so I don't have any disclosures. It's obviously a very complicated subject, as we'll get into. So the first point is, what is the difference between infection and sepsis? So I think most people know what infection is and what sepsis is, but have difficulty describing it. So in this cartoon, the patient has pneumonia, which is obviously sepsis. The other patient has some cellulitis, and that is infection. However, we need to be more precise in our definition of sepsis. So in 1992, SCCM and ACP came up with the sepsis 2 definitions and came up with the SIRS criteria. And I think this is very important to understand. So SIRS was described as an insult with 2 of the following: either a high or low temperature, a tachycardia with a heart rate of greater than 90, respiratory rate of greater than 20, a high or a low white cell count, and 10% bands. So as we said before, you had an infection, which is a localized infection. Sepsis was then defined as SIRS with a presumed or confirmed infectious process. So if you had infection plus the SIRS criteria, that was sepsis. And then going on in this continuum, severe sepsis was defined as sepsis with organ failure. And then if you had refractory hypotension, so this is blood pressure not responding to fluids, you called that septic shock. And this paradigm served us quite well for many years. However, in 2015, this paper came out, Systemic Inflammatory Response Syndrome, Criteria in Defining Severe Sepsis. So they evaluated patients with sepsis who were SIRS positive and SIRS negative, and they found that 1 in 8 patients who had sepsis was in fact SIRS negative. However, it means that 7 out of 8 patients were actually SIRS positive, which is not bad. Anyway, it seems like people freaked out about this and then decided that they had better get together and come up with some new definitions. That's what people do. So in 2016, they came up with the 3rd international consensus definitions for sepsis and septic shock. So this is sepsis 3 as opposed to sepsis 2. So sepsis 3, sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. It's operationalized by organ dysfunction, can be identified by an acute change in the SOFA score of greater than equal to 2 points. Now, obviously, one can see the problem with that is almost no clinician actually measures the SOFA score routinely. They then define septic shock as patients with sepsis who required vasopressors to maintain a MAP of 65 or having an elevated serum lactate of greater than 2. As you can see, that the definition of severe sepsis then fell away. In addition to this definition, they came up with the Q-SOFA or quick SOFA as a way of screening for sepsis with the respiratory rate of 22, augmentation, or a systolic blood pressure less than 100. However, all did not go well. So this was a meta-analysis in Annals of Internal Medicine. The conclusion was Q-SOFA had poor sensitivity and moderate specificity for short-term mortality. The SIRS criteria had sensitivity superior to that of Q-SOFA, supporting their use for screening of patients and as a prompt for treatment initiation. So it seems that Q-SOFA was a step backwards, and consequently many people still use these SIRS criteria as a screening tool for sepsis. So sepsis 3 has really much to do about nothing. So really, in reality, what is sepsis? So sepsis is probably best defined as infection plus some degree of organ dysfunction, just to make it simple and easy. So what is the national, regional, and global incidence of sepsis? Well, it's truly quite astonishing. This was a paper published this year. In 2017, it was estimated that 50 million people had sepsis worldwide, with a sepsis-related mortality of 11 million. So at the moment, we're all obsessed by COVID. While COVID is important, just to put in perspective, that COVID has killed 1 million people worldwide, while that of sepsis is close to 11 million. The human cost is enormous. In the US, about 300,000 people die of sepsis each year. Sepsis survivors have a short life expectancy, have an increased risk of major adverse cardiovascular events, have a high incidence of cognitive dysfunction and post-traumatic stress disorder. This is the post-sepsis syndrome, impaired quality of life, and more likely to commit suicide. In addition, the financial costs are enormous. Sepsis is the single most expensive in-hospital diagnosis at a cost of about $23 billion. You can see it dwarfs almost every other disease. So what is the incidence of sepsis? Is it going up or down? This is an interesting slide because if you look at this slide over 2003 to 2011, the incidence of sepsis went up quite dramatically, whereas the incidence of pneumonia stayed the same, intra-abdominal infections and urinary tract infection stayed the same. These are common causes of sepsis. So how does one explain this anomaly? And it's most likely due to changes in coding and definition. And just to be cognizant of the fact that the DRG for pneumonia pays $5,800, whereas the DRG for sepsis pays $12,098. So there are financial incentives to coding for sepsis. So when one talks about sepsis, so this is a study looking at temporal changes over time. It's important to understand how sepsis is defined. So there are things called explicit sepsis code. So an explicit sepsis code is a patient who's coded specifically for severe sepsis or septic shock. There then are these implicit codes, which is kind of a contrived code. So what they do is they combine a code for one infection and a code for organ dysfunction and come up with the implicit codes. Probably the most accurate is actually if you do a chart review and you actually look at the clinical criteria. So if you now look clinical criteria without lactate, it's probably the most accurate way of diagnosing sepsis. So you can see that depending on the way you diagnose sepsis has an enormous impact on the incidence of sepsis and also the adjusted hospital mortality. So if you use clinical criteria without lactate, you can see that the hospital mortality has stayed exactly flat. So the way you diagnose the disease is really important. And it's probably best highlighted by this so-called performance improvement exercise by Kaiser Permanente. So you can see on the top graph is the sepsis diagnoses per 1,000 hospital admissions. In 2008, they changed the definition, which included lactate, and they started using the SIRS criteria. You needed one SIRS criteria. So if you came to the ER with a high respiratory rate, you had sepsis, even if your underlying condition was COPD or asthma. So you can see what happened by changing the definition. They had an exponential explosion of patients having sepsis. If you look at the mortality at the bottom, you can see the mortality went down, including using early goal-directed therapy. And that was primarily driven by the fact that most patients who were diagnosed with sepsis, in fact, did not have sepsis. And the same thing happened in the UK. You can see when they changed the definition and coding of sepsis, there was a rapid spike in cases. So one has to be really careful when looking at these epidemiological studies. So moving on to the pathophysiology. So William Osler, over 100 years ago, said, except for a few occasions, patients appear to die from the body's response to infection rather than from it. And clearly this was a very astute observation that he made. So indeed, it's the host's response to the bacteria rather than the bacteria itself which causes the disease. So we have what are PAMPs, pathogen associated molecular patterns. So we have LPS or peptidoglycan recognized by your toll receptors. They're through a intracellular cascade results in the activation of NF-kappa B and other inflammatory mediators. These then result in the transcription of more mediators, production of nitric oxide, activation of macrophages and neutrophils, and then this develops into this inflammatory cascade. So if you expose a human white cell to LPS, it results in the alteration of gene expression of over 3,700 genes. So you can understand how complicated this is. It alters the genome of a quarter of your genes. And these are genes for pro-inflammatory, anti-inflammatory cytokines, chemokines, adhesion molecules, clotting factors, stress proteins. So obviously this is an exceedingly complicated process. In addition, it's likely that the patient's individual genetic makeup determines the gene expression and the expression of these molecules. And indeed, sepsis is a genetic disease. This is a fascinating study done some time ago, looking at looking at twins who were separated at birth. And what they found that is if your biological parent died from sepsis, you were 10 times more likely to die from sepsis than if neither had died from sepsis. So this is the traditional sepsis model, that you have the cytokine storm with a hyperinflammatory response. This then transitions to a hypoinflammatory response, or what's called CARS, compensatory anti-inflammatory response syndrome. And then what happens is the patient then goes back, arrow A, to homeostasis, or in some patients there's a prolonged hypoinflammatory phase with immune dysfunction. However, we figured out that it's actually much more complicated than this. So with infection, you have a balanced inflammatory response, which rapidly restores homeostasis. However, with sepsis, one concurrently has excess inflammation and immune suppression. And these two processes occur simultaneously. So in the revised model, you can see you have SIRS and CARS happening simultaneously. Patients can die early from multi-organ failure from a cytokine storm, but as they recover, both SIRS and CARS come back to normal and you have immune homeostasis. However, what happens in a bunch of patients, a group of patients, is they have chronic critical illness, which is characterized by persistent inflammation and progressive immunosuppression, and this is called the PIC syndrome. So patients can recover or they can progress to this chronic inflammatory disease. Now, what is quite fascinating is if you look at the patient's inflammatory biomarkers a year after discharge. So these were patients with septic shock who had survived. They then studied them a year after their discharge and found that the majority of patients still had elevated levels of inflammatory mediators. So this is quite remarkable. A year after the disease had resolved, they still had abnormalities of the immune system. And probably this is what underlies the post-COVID syndrome, is that patients don't return to a normal immune status. So looking at the clinical aspects of sepsis, in general, about a quarter of patients have gram-negatives, a quarter have gram-positives, 20% have mixed infection, 3% have fungal infections. So fungal infections are common and usually associated with catheters, lines, devices, and immunosuppression. Anaerobes are distinctly uncommon. So while many patients get treated with anaerobic drugs, anaerobes are quite uncommon. And about a quarter we have no idea. In terms of the primary source of infection, it's not that complicated. So if you go down to the ED and you think the patient is septic, the most likely source is the lung, followed by the abdomen, followed by primary bacteremia, followed by urosepsis, as was outlined in one of the earliest slides. So the commonest, in most studies, about half of patients have pneumonia, and then intra-abdominal sepsis, primary bacteremia, and urosepsis. And sepsis is a systemic disease because these release of inflammatory mediators, it affects all organ systems. So patients may present with altered consciousness, confusion, psychoses, respiratory signs, altered liver function, cardiac features, renal involvement, coagulation involvement, neuropathy, myopathy. So it is a systemic disease with multi-system organ involvement. We're interested in the hemodynamics, and this is really important as we'll get to. It's important to note that about 80% of patients with sepsis or severe sepsis or septic shock develop vasoplegic shock. And this is predominantly due to venodilation. And this is mediated by nitric oxide, activation of potassium channels, and low vasopressin levels. So the majority, but not all, develop vasodilatory shock, which is due to venodilation. Patients have leaky capillaries due to abnormality of the glycocalyx and endothelial junctions. However, this only becomes relevant when patients are volume overloaded. In addition, they have myocardial depression with diastolic dysfunction. And again, this is mediated by nitric oxide and myocardial edema. So again, the hemodynamic derangements of sepsis, you have increased pulmonary vascular resistance. One has decreased contractility. Most importantly, increased ventricular compliance. One has decreased arterial resistance. vasodilation, and then marked increase in venous capacitance, venodilation. So we're now going to talk about the identification and diagnosis of sepsis. So obviously the SIRS criteria are a starting point, but obviously patients can have a tachycardia and tachypnea for a whole bunch of other reasons. So it's a starting point. Then you want to look for other signs, confusion, hypotension. We're going to come down to some specific diagnostic tests. A procalcitonin greater than 0.5, a bandemia, a lymphopenia, thrombocytopenia, and a neutrophil lymphocyte ratio greater than 10. So what happens with sepsis is your lymphocyte count goes down, your neutrophil count goes up, so the ratio of neutrophils to lymphocyte change. So this is a study which we recently published entitled The Ability of Procalcitonin, Lactate, White Cell Count, and Neutrophil Lymphocyte Count Ratio to Predict Bloodstream Infection, analysis of a large database. We had over 1,700 patients. As you can see, so these are receiver operating curves. The test with the best diagnostic accuracy was procalcitonin, AUC of 0.83, which is very high. Second was neutrophil lymphocyte count ratio, was 0.68, which was okay, but not fantastic. And then you can see lactate and white cell count were completely useless. And this is really important because patients will come to the ER and they'll get a lactate or a white cell count to diagnose sepsis. These are completely useless tests, completely useless. So procalcitonin has the highest diagnostic accuracy. So there are other studies which support this. Adding procalcitonin results to clinical assessment improves the accuracy of the early diagnosis of sepsis. You can see the very high ROC. And again, you can see that lactate is completely useless. Another study, does serum procalcitonin aid in the diagnosis of bloodstream infection, regardless of whether the patient exhibits SIRS response? Only procalcitonin was independently associated with bloodstream infection, while the SIRS criterion and serum lactate were not. So I think this makes a really strong point that SIRS is okay to screen patients, it's not a diagnosis, and serum lactate is complete waste of time in order to diagnose sepsis. However, one must not be led astray. This is a really important study looking at patients with septic shock. So these patients had septic shock, and what they found is 37% of patients presented with vague symptoms. So these were patients who do not present with fever, chills, and rigors. So one has to be really alert to the fact that patients who present with vague symptoms may have sepsis. And obviously you need to work these patients up for sepsis. And it's usually the elderly and the young in which this occurs. And if you actually look at what the vague symptoms were, these are fatigue, malaise, weakness, altered mental status, confusion, nausea, vomiting, shortness of breath. So patients can present with really non-specific signs and symptoms, somewhat similar to COVID. So you really need to be on the lookout for sepsis. We're now going to talk about the treatment of sepsis. Obviously, it's somewhat complicated and controversial. So I'm sure all of you are aware of this fairy tale. So this fairy tale called Early Goal-Directed Therapy was published in 2001. It was a tiny study with bogus data. And unfortunately, based on this fairy tale, people like fairy tales like the same way like they like Santa Claus and the Tooth Fairy. Based on this fairy tale, this mode of therapy became standard of care for over 15 years. So what is early goal-directed therapy? This is the algorithm, but essentially the important part is this part down in the corner. So what they did is they measured mixed venous O2. If the mixed venous O2 was less than 70, they gave blood and they gave inotropes to increase it. In addition, they drove the hemoglobin or hematocrit above 30. So that's early goal-directed therapy. They were trying to improve oxygen delivery by giving red cells and inotropes and fluid. So we should see here the goal in the fluids was to keep the CVP above 8, and we'll come to that. So then it took a whole bunch of time, almost 14 years, to debunk this fairy tale. So in 2014 and going into 2015, we had 3 large randomized controlled trials from the US, Australia, and Europe, which showed that early goal-directed therapy did not improve outcome. And indeed, in the sicker group of patients, it appeared that early goal-directed therapy was harmful. So that put to bed early goal-directed therapy, and indeed all the elements on which the Surviving Sepsis campaign was based, i.e. mixed venous O2, central venous pressure, hematocrit, and lactate. So we're now moving on to the cure for septic shock. So if you do the right things in the right order and with some clinical judgment, patients should not die of septic shock. However, there's not one magical elixir, there's no silver bullet, it's an approach. The first and most important is early diagnosis. That's why we went through the diagnosis with in some detail, looking for the clinical criteria supported by procalcitonin, maybe neutrophil lymphocyte ratio. Early diagnosis is essential. Sepsis is no different from stroke and AMI. This is a time-sensitive disease. And timing is important. And treatment starts in the ED with early administration of the correct antibiotic in the correct dose. Secondly, source control. You must control the source. If there's an infected catheter, it must come out. Thirdly, a conservative physiologic approach to fluid resuscitation, which we'll talk about. The early use of norepinephrine, the metabolic resuscitation protocol, or the HAT protocol, hydrocortisone, ascorbic acid and thiamine, which we're not going to discuss further. You need to have a team approach. You need to have a team working together to support the patient, as well as state-of-the-art evidence-based supportive care. So the goals of hemodynamic support, and as you'll see, this has changed slightly. You want to target a MAP of 60, just above 60, 60 to 65. You want a heart rate of below 100, but that's not with a beta blocker. It's with adequate resuscitation. You want to ensure adequate perfusion, and this is determined clinically. If you're going to measure cardiac output or cardiac index, you want it greater than 2.2. And if you were silly enough to actually measure the central venous pressure, you actually want it low, below 8. There's absolutely overwhelming evidence that pushing the CVP above 8, as was suggested in early goal-directed therapy and in surviving sepsis, increases the risk of death and renal failure. So just to reinforce that, pushing the CVP above 8 increases the risk of death and renal failure. So let's talk about blood pressure. So this was a study done in France in 2014. And the question was, if targeting a MAP of 60 to 70 is good, why don't we target an even higher blood pressure to improve organ perfusion pressure? So they did this study, and you can see dichotomized patients pretty well into a high and a low target group. And what they found, no difference in mortality. So more recently, like this year, we have the S65 study. So what they did in this study is they did the opposite. They wanted to see if permissive hypotension, i.e. targeting a MAP of 60 to 65, reduces mortality at 90 days in ICU patients aged 65 or older with vasodilatory shock. So they randomized them to this permissive hypotensive group compared to a normal group in which they targeted a MAP of 65 to 70. And again, you can see this graph shows pretty good dichotomization according to the target blood pressure. And again, what did they show? No difference in outcome. So I think this clearly states that in most patients, what you want to do, target a blood pressure of 60 to 65. Just remembering that high doses of pressors can cause significant complications. So you have to balance the use of pressors versus your target MAP. And a MAP of 60 is actually fine. So what about fluids next? So we're not going to go into the choice of fluid, but the choice of fluid is Ringer's lactate, and you want to use a light protocol. There's no place for abnormal saline. So this is an important study, again, almost three decades ago. So they took patients with sepsis and septic shock. They gave them a liter bolus, which we wouldn't do today, but they were challenging the patient's cardiovascular system. So you can see the top arrow is what happens in a normal patient. You give a liter of fluid, you increase preload or end diastolic volume, that then increases stroke volume or left ventricular stroke work index. So that's what normally happens. You can see what happened in the group of patients with sepsis. The curve is shifted down. There was a smaller increase in end diastolic volume with a smaller increase in stroke volume because the patient has decreased contractility as well as decreased compliance. Now look what happens in the patient with septic shock. They gave a liter of fluid with no benefit. Did not increase end diastolic volume or stroke index. What it significantly did is increase filling pressures and edema. So this study done 1988 showed that patients with septic shock respond poorly to fluids. And people seem to have got this because fluids was regarded as the cornerstone of treatment for sepsis. But it gets worse. So clearly the reason you give patients a fluid bolus is to increase stroke volume. That's the only reason to give fluid, not to fill the tank, but to increase stroke volume. This is an intriguing study because they looked at fluid responsiveness over time. So you can see at baseline, about half of patients in septic shock responded to fluid. And this is really, really important because obviously what this means is that 50% of patients didn't respond, and fluid resuscitation cannot be regarded as the main way of resuscitating patients or the cornerstone of resuscitation. And you can see with time, rapidly, patients became almost completely fluid non-responsive. So this idea of flooding patients with fluids does one thing and one thing only, and that's drowning the patients with fluid until they arrest. So this was a study done at Mayo. Most people would regard Mayo as a good hospital. They looked at 405 patients who were resuscitated with early goal-directed therapy at 24 hours. 67% of patients had clinical evidence of fluid overload. At 72 hours, it was 50%, and fluid overload was associated with doubling the risk of hospital mortality. So this is a really efficient way of increasing hospital mortality. This is the classic study. This is the FEAST study. I think every clinician needs to know about the FEAST study. This is such a classic study. So in this study, they took over 3,000 kids in sub-Saharan Africa who had severe infection, severe sepsis, and they randomized them to no bolus versus an albumin or saline bolus. This study could never have been done in the US because people would have thought it unethical not to give a fluid bolus to a critically sick child. And this is the mortality. You can see the mortality was significantly lower at 48 hours and at 4 weeks in the kids that were not given a fluid bolus. It's a remarkable study. And there wasn't a single subgroup of patients who actually benefited from fluids, regardless of the hemoglobin, the lactate, the base deficit. They couldn't identify a single group of patients who actually benefited from a fluid bolus. Interesting, the cause of death was not fluid overload, but cardiovascular collapse following initial hemodynamic improvement. So this is a fascinating concept that the fluid undermined the normal hemodynamic response to shock and resulted in cardiovascular collapse. And as you will see, fluid paradoxically causes vasodilation. So this is a very important study. So this is an animal model done in Australia in sheep. They got lots of sheep. So this was a ovine endotoxin model which mimicked human sepsis. And they randomized the sheep to the fluid resuscitation group, in which they got 40 mils per kilo over an hour, much like surviving sepsis, or no fluid, much like in the FEAST study. And then they looked at their pressor requirement. So paradoxically, the group of sheep that got no fluid had a lower pressor requirement than the sheep that received fluid. And the reason, as you will see, fluid in this setting becomes a vasodilator in the setting of vasodilatory shock. It does what you don't want it to do. The lactate went up. When you looked at the AMP was significantly higher after resuscitation. Atrial natriuretic peptide is a vasodilator, so this is part of the reason. AMP also damages your glycocalyx, increasing capillary permeability, and you can see hyaluron, which is a marker of endothelial damage, went up significantly. So the conclusion, fluid resuscitation resulted in a paradoxical increase in vasopressor requirement. Additionally, it did not result in improvements in any of the measured microcirculatory or organ-specific markers. The increase in vasopressor requirement may have been due to endothelial glycocalyx damage, secondary to AMP-mediated glycocalyx shedding. So again, this study really supports the FEAST study and the other clinical studies. So we did a study where we looked at fluid administration in patients with severe sepsis in a large database. We looked at every drop of fluid given in the first 24 hours, which included IVs as well as mini bags. What we then did is we did a predictive model. So we could predict for every decile of fluid what the patient's predicted mortality would be. And what we found, if patients received more than 5 liters of fluid, the actual mortality in red was significantly higher than the predicted mortality. Going the other way, in fact, the opposite happened, that less resuscitation was beneficial. So this is really important because people think if you under-resuscitate, you increase mortality. There is not a single study done in patients or in animal models that demonstrate in the setting of sepsis or ARDS that less fluid compromises outcome. In fact, the opposite is true. So you can see for patients who received in excess of 5 liters, there was a 2.3 increase in mortality per liter of fluid, whereas if you got less than 5 liters, your mortality went down 0.7 per liter. And just to note that the mean amount of fluid given was about 4 liters, which is significantly less than what is currently recommended by this drowning fluid protocol. So this is real life data from the United States, 20,000 patients. So in reality, patients get much less fluid than is generally recommended or suggested, 4 liters a day. This is a study published 2 weeks ago, fluid overload and mortality in critically ill patients. Fluid overload and cumulative fluid balance were both associated with more pooled mortality after 3 days in the ICU. So if you were fluid overloaded, your relative risk was increased eightfold with a fluid overload. So obviously, giving too much fluid does exactly as I've told you. It results in salt water drowning. So this is the way it should be done. This is a very good study recently published in CHEST. So sorry, this is CHEST and not critical care medicine. In this study, they followed the algorithm that we follow. Basically, patients were randomized to usual care or an intervention. In the study, intervention fluid was guided by passive leg raising maneuver and using non-invasive cardiac output monitoring. So patients were only given fluid if they were fluid responsive. Isn't that a thought? They only gave fluid to patients who were fluid responsive. The study was limited by its small size. It wasn't powered for mortality. But you can see at 72 hours, the amount of fluid given to the intervention group was significantly less. Paradoxically, and every study finds the same thing, the less fluid you give, the lower the risk of renal replacement and kidney failure, because as I said, pushing the CVP above 8 is the best way of causing renal failure. And again, paradoxically, the less fluid you gave, the less your requirement for the ventilator and length of stay. And the same held for presses. The mortality was 15% versus 22%, so there was a trend. However, the paper was not powered for mortality. And I do apologize, this was published in CHEST and not in critical care medicine. So the hemodynamic derangements of sepsis, fluids increase vasoplegic shock, they increase leaky capillaries, they increase myocardial depression, they increase diastolic dysfunction, and indeed they increase mortality. So one needs to ask, where's the blood? Most people think the blood's in the capillaries or the arteries. The reality is 60% of your blood volume is in your veins. And what happens when you have sepsis, you have profound venodilation. So this is not a volume depleted state. The patient hasn't lost liters of fluid. This is not severe diarrhea or Ebola. So what happens is you have profound venodilation, in your splanchnic bed, and in your skin. As a result of this, your unstressed blood volume increases, and you have decreased venous return. So obvious, you don't have to be a rocket scientist to figure out what you do. You want to give a venoconstrictor, such as norepinephrine, which will then venoconstrict, increase venous return, and increase cardiac output. It's important to note that you do this without giving fluid because the patient is not fluid depleted. And this is well demonstrated in the study. Early administration of norepinephrine increases cardiac preload and cardiac output in patients with life-threatening hypotension. So they have septic shock, they get early norepinephrine. So you can see it increases cardiac index, increases stroke volume, it increases the volume in the heart, the JEDI, and increases SVR. So the JEDI is the preload. So by giving norepinephrine, you increase preload, you increase cardiac output. So this is another cool study. They looked at the timing of administration of norepinephrine in septic shock and found that with each hour delay in the administration of septic shock, the odds ratio of death increased. Again, another study looking at the early start of norepinephrine in patients with septic shock. You can see at the bottom is early vasopressors. This line is delayed vasopressors, and this is the amount of fluid given. So obviously, if you venoconstrict, you will increase venous return. If you don't do that, the patient has decreased preload. You can give fluids with its transitory benefit. So you can see in this study, patients who received delayed vasopressors received significantly more fluid, mils per kilo. So you can see if you use early vasopressors while you're giving fluid, we're not saying don't give any fluid, we're saying give fluid based on fluid responsiveness. You can see the group of early pressors received significantly less fluid as a group. And obviously, if you look at mortality, so a low mortality is a good thing, just in case we didn't know. The patients who got vasopressors early had a significantly lower mortality. So what we're saying is give a little bit of fluid in patients of fluid responsive. Only in patients of fluid responsive, base your ongoing fluids on fluid responsiveness and use early norepinephrine to increase venous return from venodilation. So what about angiotensin II? This was a study published sometime in New England Journal of Medicine. What it basically showed, as you would expect, is angiotensin II is similar, increases your blood pressure. It's a vasopressor. However, in the study, giving angiotensin had no effect on organ function or outcome. It should, however, be noted that many studies have treated patients with an angiotensin receptor blocker or an ACE and actually showed improved outcome. So you can't have it both ways. You can't have angiotensin blockers and giving angiotensin being beneficial. And I bet on not giving angiotensin. So as you can see, there's a changing paradigm in one's approach to sepsis and septic shock. So the revised approach at the bottom, early antibiotics, really critical. You want to give a little bit of fluid, and the fluid must be given sensibly, must be guided by physiologic assessment. You need to assess fluid responsiveness. Just blindly giving liters of fluid will result in saltwater drowning. You want to start early norepinephrine. At the same time you start fluids, you use a low dose, you can give it peripherally. And if you start it early, it tends to come off early. And then the metabolic resuscitation protocol started early, immediately, in the emergency department. So there are a few studies looking at HAT therapy. which were negative. Unfortunately, these studies were started at least 24 hours after the patient presented. So that's not going to work. So this is the revised approach to fluid resuscitation. So to conclude, sodium chloride is a poison to all people when given in large doses, and occasionally very toxic in small doses to certain class of patients, i.e. those with sepsis. This was made by an obstetrician and gynecologist, the statement, in 1913. So this should not be a new concept. So I thank you. And if anybody is out there and they can hear me and they have questions, I'd be happy to answer.
Hey, Dr. Marik, this is Montez. I have a quick question.